and good evening. I'm Melisa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. Medical costs are rising and so are the premiums for health insurance. So to tackle this, the government is considering introducing a diagnosis-related group pricing system. But is DRG the right prescription for Malaysia's healthcare woes? Or will it create new challenges for hospitals, doctors and patients alike? So joining us now to discuss this further, I have Azrul Mohd Khalib, who is the CEO of the Galen Centre for Health and Social Policy. Azrul, thank you for being on the show with us today. Maybe we can begin our conversation today helping us better understand what DRG is. What might DRG pricing look like in practice in a Malaysian context?
Well, Melissa, diagnosis-related grouping, or DRG, is basically a system where they look at categorizing patients with similar clinical diagnosis and putting them into different categories in order to help better control and manage hospital costs as well as determine reimbursement rates. The intention is really to ensure that there is the possibility of putting patients into different categories for which there are costs incurred according to the different levels or severity of the disease that they are being treated for. It uses a case mix system, so it basically clumps people together according to the different diseases and different cohorts. So if I were to give you an example of a case mix, you can imagine a 52-year-old woman with breast cancer being diagnosed or presented at stage 2 and HER2 positive with no comorbidities. And this is something that if you were to consider this person, if she has comorbidities or more complexity, it would be a different case mix system, a different level of complexity, and therefore with increased cost. So the idea is for each of the different categories of patients, there will be a cost incurred and looked at as a bundle rather than as individual costs. So when you look at the way Malaysia does its billing, or at least in terms of private healthcare, it is based on a fee for service, which means every single item is being categorized and costed. So you then end up with a very large bill very often for which both the patient and the payer is forced to look at, but also it can be incredibly complex. So with the idea of putting people in a DRG case mix approach, it's all bundled up together and it becomes much more simplified. And therefore, you would only be looking at it maybe like a few lines of billing rather than a much more longer line. So the idea here is to manage costs, but also avoid overcharging or encourage people to impose more charges on hospital bills. So the idea is to, instead of looking at every individual component or cost of a car, you're just paying for the price of a car.
Okay, so using this case mix approach, Azrul, is there a risk of it being a kind of one-size-fits-all approach? How do we think about cases that are more complex, cases that are more high risk, or requiring complex care? How do we think about that?
So definitely that has been anticipated, and when you look at how Malaysia has gone into the DRG case mix approach, which it has been looking at since at least 2010, and there are several teaching hospitals now already utilizing this approach, and the Ministry of Health has itself been considering quite seriously about taking the case mix approach towards the reimbursement. So it anticipates that there are levels of severity of illness. So in this particular case, if you imagine severity of illness A, B, and C, A being the least complex, much more straightforward, no real comorbidities, and you're being straightforward being treated for that illness, versus C, which could be the most complex and much more costly form of treatment. So the idea is to be able to put people into these categories to enable for the billing to be easily accommodated into the system, but also not leaving out the possibility of there and being an escalation. So a patient could originally be admitted as being in category A, but later on during the course of the treatment could end up being in category C because of the complexity that may occur during the course of a treatment. So in this way, you are able to help the reimbursement or the payer, in this case, either the Ministry of Health or the patient itself, to be able to just look at how much they have to pay rather than go into the nitty-gritty and nuts and bolts of the actual treatment itself.
Okay, so I have to ask you whether you think a DRG pricing system is actually the right approach to tackle the rising cost of healthcare. I mean, that's essentially the main thing, right? So does it actually address the rising medical costs, or are there other solutions that you think we should also consider?
Well, it's very important to learn from the experiences of other countries. And the DRG case mix approach has been adopted in at least 40 other countries around the world. We have Australia, the UK, Thailand, China, Philippines, United Arab Emirates, South Korea, and of course the United States. They've been looking at this as a funding and reimbursement tool. And the reality here is that this is really about healthcare financing. This tool is really to keep costs under control and to try to prevent from there being an overcharging of or overtreatment of patients, which is currently what is happening in a lot of, especially private hospitals, where because of the need to address things like medical legal concerns, also to be cautious, to also anticipate all possibilities, there is a tendency to go beyond what is most needed for treatment of a particular disease, and to prescribe more treatment, to do more diagnostic tests, and so forth. So the question here is really, if we adopt this today, is this going to help healthcare inflation? And the reality is that it has the potential to do so if we are able to sufficiently capture the actual costs incurred in the course of treating a particular disease. So we know from healthcare that nothing is straightforward. It really isn't like buying a car, even though I use the analogy of buying a car. It really isn't. A patient could come in with presentation of a straightforward case and then end up later on even dying as a result of a diagnostic test that during which a complication may occur. Person goes into cardiac arrest and then later on passes away. So we need to be able to anticipate what's possible, but also to understand that healthcare involves a continuum of care which is very complex, has a lot of variables. It's not easily able to be shoehorned into addressing a budget problem and then just using a simple tool to address it. So right now, I think the DRG case mix approach is definitely the way forward to helping to manage healthcare costs, not just in the private sector, but also in the public sector as well, because it's able to properly identify where the resources are going to be needed to address disease. So even today in the public sector, I would argue that if we did it properly, we can actually ensure that places where more funding is needed is able to get the funding and to reallocate those resources appropriately. Even in government today, they haven't adopted the DRG case mix properly because they're still relying on historical budgeting for the purposes of getting that budget every year. And if you use the DRG case mix, it would change that entirely. But it's not as straightforward. there's a lot of concerns, especially in the private hospital side, where you need to even amend legislation in order to get DRG case mix to be adopted into the private hospital setting.
Okay. Well, apart from barriers or obstacles around legislation, there's been a lot of pushback, right? A lot of resistance to this, saying this is not the right approach. What do you make of that? How do we think through why DRG is getting so much pushback, particularly from private healthcare providers?
So, from a business perspective, it's quite straightforward. Bundling means that you are going to look at how much it's going to cost overall, which means you are going to take cost containment measures to maximize your profit within a particular, case mix category. So, if today, because it's not regulated, the additional charges for consumables, for the use of things like kidney dishes, wheelchair, the heart monitor stand, and so forth, all of which you can add on, and there is no limit as to how much you can add on. With the DRG case mix approach, that will be curtailed and be contained within the categories which I mentioned just now, category A, B, and C. So you can't go beyond that without justifying the complexity that is going to result in it. So the problem here really is for private healthcare, when they're looking at it, it will force them to relook at the way they're utilizing equipment, how they're charging that equipment, and most importantly, the profit margin that's going to be involved in it, because it's going to be capped within a certain limit. So the problem here is that it will address a problem, meaning it could help with healthcare inflation to be brought down. But one thing you might be interested to know, that the pushback could even come from patients themselves, because even though you say, you're going to be paying less, but the reality here is that patients today want to know what they're being charged for. And so with the DRG case mix approach, that is no longer going to be the situation where you're going to see 13, 14 pages of billing from a 2-night stay in hospital. It's going to be possibly a single page where you're going to be having, DRG case mix Z0123, and then there are a few more lines, and then that's how much you pay. And so even patients themselves, especially if they're paying out of pocket, they're going to ask, what am I paying for? Why am I paying this much, and so forth. So the legislation today requires there to be itemized billing, where there needs to be breakdown of every single cost incurred and how much it's going to cost. So you're also going to have to amend the Private Healthcare Facilities and Services Act, or the Act 586, in order to introduce the DRG case mix approach for the private healthcare. So there's going to be a lot of pushback because it requires a lot of work and preparation to actually adopt, not just in the private sector, but also in the public sector as well. Because, Melisa, there is a reason why the DRG case mix approach hasn't been widespread adopted in the public healthcare sector, much less the private healthcare sector. So imagine if the public healthcare system itself is reluctant to wholesale adopt it into the way they look at budget management. Now you're imposing it on the private healthcare. You've got to ask yourself, why didn't you do it earlier? So the issues here are there are quite a number of reasons why we are sort of not really there yet to adopt DRG case mix for both public and private. And I'll just name 5 here. The first one is definitely, I think I mentioned just now, looking at the mindset of healthcare delivery. Right now we are looking at supply driven models. So there is demand and then there's supply, but there's less emphasis on value, on efficiency. So with DRG case mix, it's really about outcomes. Are we improving on that? Are we delivering on providing better care for patients? Are there fewer patients? So there's a lot more emphasis on the budget that's been given rather than the performance of that care that's being provided. So currently our healthcare system is not really that suited because we're not emphasizing enough on value-based care. The second one is on digital healthcare systems. Our systems, especially in the public healthcare systems, are antiquated. It really is. It's archaic. There's some systems running Windows XP. So we
All
need
right.
to actually invest in that in order to get it done. So, cost accounting at the patient level, capacity for the healthcare providers to deliver on that, and most importantly, the regulatory reform, which I mentioned. So there are 5 factors there.
Azrul, thank you so much for laying that out for us. Appreciate it. It's a complex issue and one that requires a lot more discussion going forward. But thank you for your time. That was Azrul Mohd Khalib from the Galen Centre for Health and Social Policy. Another quick break here on Consider This. We'll be right back. Stay tuned. Hi, welcome back to Consider This. I'm Melisa Idris. Let's continue our discussion about the government's plan to implement diagnosis-related pricing, or DRG, diagnosis-related pricing, group pricing. This is to address the rising cost of healthcare and provide a standardized cost structure for treatments. Joining us now is Datuk Dr. Ahmad Faizal Perdaus, who is consultant respiratory physician at KPJ Damansara Specialist Hospital. He's also the president of MERCY Malaysia. Dr. Faizal, thank you for being on the show with me today. Can I ask you what your main concerns are when you first learned that the government is considering DRG pricing?
Thank you, Melissa. Thank you. First and foremost, we have to acknowledge that we have come to a point where there is a health financing crisis in Malaysia. There is no doubt about that. And looking at reports not only coming from the private healthcare sector, but also recently, of course, the news from UMMC that they are also raising their prices for both outpatient and inpatient admissions, shows that our healthcare system, both public and private, is very badly in need of some reform and some look forward and some new way of working. So that's very obvious. That's the first predicate, if you like. Now, going directly to the question, there are 4 points of concern and why some, in fact, most private medical specialists are concerned. Should there be a rollout of the DRG, and one perhaps overarching aim or goal, if you like. So the 4 concerns that we have are, number 1, given the predicate that we do have a health financial crisis, given that there is escalating health inflation over the last decade, and we have one of the highest in the region and globally, which is not very good, yeah. And most of it is driven both by the private healthcare sector as well as private pharma, big pharma, as well as private medical equipment supplies, etc., etc. There is no doubt there needs to be a look at the health financing status. At the same time, this has driven private medical insurance premiums to go up drastically. So the first point for this is on the DRG is that we are not convinced that rolling out the DRG per se, now I have to qualify that statement, rolling out the DRG system per se, without modification, without hybridization, without looking at variations, and also the fact that we do not have a national health insurance system. We also do not have an integrated health system. We have a dichotomous public and private dual system in this country. Rolling out the DRG may not even address the issue of private healthcare, in particular private hospital prices escalating over the years, simply because ruling out the DRG may give private medical insurance some relief, yeah, in terms of a cap as to how much can be spent on a particular problem or issue, but that does not mean that the excessive or overcharging on the part of some private hospitals will go away. The DRG may not be able even to address that, because as pointed out in some of the cases that have been presented to the Parliamentary Special Select Committee and to Bank Negara Malaysia, etc., some of the charges that are allegedly high or overcharged are in the non-medical areas of service, yeah, of of the private hospital total billing. It's not in the medical care aspect, except for investigations like lab and diagnostic imaging investigations. So it may not even address the overcharging issue. Yeah, so that's the first concern. That's the first concern. The second and third concerns, however, are our biggest concerns. And as private doctors, as medical practitioners, we are bound by our Hippocratic oath and by our ethics to look at our patients first, always. So what we worry is, if the DRG is being implemented without, like I said, without modification, without further discussion, without looking into it properly, without further study, is that number one, there will be limitation and constraint on the treatment that is going to be given to the patient. Simply because you've already put a cap from the very beginning on the price that's supposed to be paid. Secondly, it will leave some of these patients, especially those without enough cash to top up should the DRG packages burst, with no other choice but for us and for them to be transferred when they are only half treated back to government facilities in a condition where they are only half treated. So this is our main concern. These two conditions may not be prevalent if the system is different, but we don't have such a different system. We have a dichotomous system. Yeah, the closest we have to such a system in this country is in some, not all, in some of our university hospitals where they have both private and public wings. So that is not so difficult for them to implement the DRG system, because if you were in the private wing of a university hospital, let's say University Hospital A, and your insurance package has burst, and if you do not have enough cash to pay out, you can easily be transferred over to the public wing in the same university without extra costs, without too much extra costs, without logistics issues, etc., etc. Over in our system now, people over in private hospital will now have to be transferred, whether they are ready to be transferred or not, over to government facilities during times when they may not be in the best of conditions to be transferred.
Right. Dr. Faizal, can I just jump in very quickly? So I know you were laying out the different areas, but what modifications would you propose or do you think will make DRG more acceptable or to mitigate this? Or is that concept itself fundamentally flawed?
Right. First, the DRG works best in a different type of national health system. That one is a given, which has two characteristics. One is that there is a national health insurance system in place, whereby there is a basic national health insurance for everyone. So that even the B40, M40, and lower T20, you must remember the T20 in our country, the lower part of the T20, the T2 of the T20 now, as it's currently defined, is probably only really T20 in some of our outskirts, in our rural areas. If you're in the Klang Valley, I wouldn't really call people in the lower half of the T20, because of the high cost of living. So with a national health insurance in place, and in some other countries, they have both a national health insurance and a more integrated system, whereby the public, private, academia, university hospitals are all more integrated together. Then it's easier to roll out the system. We have a system which is fairly dichotomous, I would say. Yes, there is interaction, but there is no direct link. Yeah. Yes, we can talk about public-private partnership, but that's on a different level. Yeah, that's on a different level. So the third issue that we worry about is when we roll out the DRG without further modifications, is the fact that there are issues with the private medical doctors themselves, who at the current moment only take about, on average, 10 to 15% of every total hospital bill in a private hospital setting, on average. There are situations where they get up to 20-25%, especially if there's major surgery involved in major surgical disciplines like cardiothoracic and neurosurgery. But by and large, if you were to come in for dengue or for a simple appendix surgery, the doctor's bills will be between 10-15%, at the most 20% of the bill, of the total bill. The rest will be the hospital bill. And with the DRG without modification, we are also concerned, private doctors are concerned, and to be fair to the private doctors, work very hard without much support sometimes, that that their fees, which are already scheduled and capped and are actually by act of law, they cannot increase their charges, and their fees are actually regulated for the last since 2006 under the Private Hospital Healthcare Act, under the 13 Schedule Fees Act, and so any inflation over the last 10 years have very little to do with doctors. Indirectly, yes, doctors are also a cause for inflation through the investigations and the procedures that they do, but directly through their charges, no. So we're also concerned that without any modification, the doctors will be affected. So what modification? The modifications will have to look into variability of presentation of patients, length of stay. A good example will be a patient with dengue. A patient with dengue is highly unpredictable. For example, a stay can last anything between 2 days only to maybe a week to maybe 10 days. And there is no way within those a week or 10 days that we can tell you beforehand how long you're going to stay, depending on how you do, on your blood test results, on your clinical presentation, on your complications, etc. So these are just some of the modification that's needed. Secondly, of course, like I said just now, if you really want to address the issue of escalating private hospital costs, there must be we must really be careful here that we don't end up doing this and miss the boat entirely. End up rolling out the DRG, and like I said at the beginning, you don't even address the initial issue, which was there in the first place. Instead, you cause other rolling problems out of it, both for the patient and the doctors especially, and all it does is just cap the amount that the insurance companies will have to pay. Now, and this is our concern. Now, that's not to say, so we are encouraged by YB Minister, who has come out twice, I think because he realizes that some constructive criticism is coming out, especially from people like ourselves, that there has to be more care, more caution, and more study into this before it gets rolled out in full. And so we are encouraged by two statements of his. One is that when he said that we won't be going down the DRG way fully, laissez-faire, etc. And the second one, he did say just a couple of days ago, I think it was out in yesterday's news, that we will be looking at this, and also we'll have to amend the Private Healthcare Act, which will take at least 6 months. So there is time. There is time for study, and this is the second last point that I need to make. That we private doctors are in full support of our Association of Specialists in Private Medical Practice, who will advocate to MOH and to MOF and BNM that private doctors be included in the discussions for this, and not the discussions be left to bureaucrats, and also, sorry to say, executives from both private medical insurance and executives from private hospital groups who are not necessarily representative of the private medical practitioners. So we insist that the private medical doctors be given space, time, and allocation to be there represented. Now, Melisa, when we talk about this, I would like to make a fair statement, I think. Look, we all know that at the moment, at least, and until there is a different system in the country, and until there is, for example, national health insurance in place, as per the National White Paper on Health. So it's an aspiration, but that's another debate and another session altogether. We don't have time for. Until that aspiration is achieved, and until the system becomes slightly more evolved than it is now, we do have the system that we have now, and we acknowledge that both private hospitals and private medical insurance have to make profit, but we also are in line with the government in agreeing that there should be no profiteering. That is probably key to this. Thank you.
Dr. Faizal, thank you so much for being on the show with me today. That wraps up this episode of Consider This. I'm Melisa Idris signing off for the evening. Thanks so much for watching and good night.